In this episode of Tell Me More About, I'm joined by Tali Chackartchi. Tali, welcome.
Hi.
You did a session in this Monaco Congress about the limitations of dynamic and static surgical guides. Now let's start with the basics. What are the recent developments, or where do I place these guides?
Well, actually, both guides, when we look at the literature reviews, they both perform in high levels of accuracy, more or less at the same level. And it's quite evident that both are much better than freehand drilling, even for very, very experienced clinicians. But I think that now, recently, we started to look a bit different about these systems, not only their advantage in the surgical field, but probably their biggest advantage in terms of planning, since we are able to see in advance on our digital file, see in advance all the limitations of the case, all the requirements, to think in advance about the best treatment options, and only then we are implementing that in the surgical field using either one of them as a guidance system.
So you would say that is one of your first key takeaways. This is just not a mere surgical tool.
Exactly. And it's important to emphasize, because many of the clinicians just do this planning phase quite fast, using the company technician to do it for them and to just briefly overview the planning. But this is the greatest advantage of these tools. We are able to see on the digital file the whole situation of the patient's mouth, our future planning, the wax up. So I would like to emphasize the great power of planning in this use of specific digital tools.
Yeah. So the idea that you are using the guide later in surgery makes you plan better, hence perhaps come to better outcomes or at least better surgery while you're performing.
Exactly. When we are implementing later on a guidance system, it helps us in a predictable way shift our planning from the virtual world, from the computer to the surgical field. And it also helps us be very predictable in what we plan, because we don't count on distractions that we might have on the surgical field. We have our plan in advance, and we have a tool that helps us implement it in a very predictable way.
Yeah, and I can see how using a guide is an opportunity in that sense. Now, in your title, we talk about both dynamic and static guide. Is there one better than the other?
I wouldn't say one is better than the other. They are different, but it's important to understand that both have limitations. Both will need experience to control the workflow, since every step of the workflow will have a process error that you as a surgeon need to control. So if you look at the literature and you see the numbers, so till the fraction of a millimeter, it's very accurate and it helps you work in a very predictable and accurate way. However, it requires a learning curve and the surgical skills to make sure, for example, in the dynamic navigation, that you don't block the vision of the camera and make some disconnections of communication, that what you see on the screen is actually calibrated to what's happening in the surgical field. Same goes for dynamic navigation. For static navigation, you need to make sure that when you drill on one part of the mouth, the guide doesn't disconnect on the other side. So actually, maybe in the past, it was perceived as a tool for beginners to replace knowledge. You have something to help you with. But today, it's quite obvious that this is a tool for advanced users. It needs experience, surgical experience. I always say that we are implementing our digital tools to become a better version of ourselves, to make the best out of our knowledge and capabilities. And not to replace the knowledge. Exactly,
that's a nice takeaway. However, I'm slightly wondered, why would you say it's now for experienced surgeons and why not for both? Because I can see how it's not only for a guide for people who are relatively new, but you say now it's more a tool for experienced.
First of all, I would say that for static guides, the most documented complication with static guides is the breakage of the guide. So you have to be able to perform the procedure freehand if you choose to use a guide. And I think this is like the guiding phrase that one should take for themselves. If you are using a guide, you need to be able to perform the operation also without the guide. Of course, it will help you be more predictable, more accurate. The surgery will go faster, but it's not a replacement for knowledge. The same as you would not imagine an autopilot. A pilot will use autopilot instead of being able to
fly the plane. So you say the guide might, perhaps in the past, but it might give a false sense of safety. You still need to be able to be ready for plan B.
Absolutely. You have to trust it, but verify. And also the second aspect is that you need to control a lot of parameters during surgery in order to take the best out of these tools. You need to make sure that you are not blocking vision. In dynamic navigation, you need to look indirectly on the screen of the computer and not in the surgical field. Also with static guide, you need to make sure that you don't shift it or move it while drilling. So it requires a lot of attention, both on the planning stage, but also during surgery.
Yeah, makes sense. Can we zoom in on a few more of these limitations that you mentioned? Let's start with those static guides. Limitation of static guides. You mentioned a few already. You need to be well experienced. You need to be very careful during surgery that everything stays in place. What else? What other things should people be aware of and consider?
Well, the biggest limitation for static guides being mentioned again and again is that you cannot change your plan intraoperatively because you fabricate a guide in advance and this is what you have. So on one hand, we would say that if you created a digital file which is very close to reality, you don't need to improvise. You have all the information that you need in advance. You just need to be able to read it and understand it. But it's not totally true, because sometimes you have some change of the clinical scenario. For example, in more advanced cases, when you do immediate implantation, if while extracting the tooth you wouldn't manage to keep the thin buccal bone and it broke, so the clinical scenario changes, and you need to be able to compensate for that. So for that, dynamic navigation can be easier for these cases. But on the other hand, with static guides, surgery is much faster, the surgical time is reduced. So both will have pros and cons, and at the end of the day, the clinician will pick a tool that will be easier for them or cheaper for them or more accessible, but then they will gain the learning curve through more and more cases that they do, and they will just keep on using the same system. I think both have their pros and cons. I wouldn't say,
exactly. But that's why it's interesting to explore those. So it's the lack of flexibility in terms of a clinical unforeseen scenario. Then you already hop on the other side in the dynamic. You say, well, you have more flexibility. However, it takes much more time. How much more time are we talking about?
With the static guide, you actually don't really need to calibrate because everything is planned in advance. So you are working kind of blindly. You just trust the guide, of course, not fully. You always need to verify. And then you just drill through it. With the dynamic guide, you need, after every change of drill, you need to calibrate. You need to make sure that when you look at the screen of the computer and what's happening in the surgical field is the same. So when you ask how much time, it very much depends on the experience of the operator. But let's say on an equal level of experience, I would say at least 30 or 40 times % more time for dynamic navigation. But then you might leave this time aside when you plan.
Of course, and then so I guess it's a bit of chance, right? Because in the case of a scenario that's unforeseen, with the virtual guide or the dynamic guide, you are faster then because you can move on.
Yeah.
Yeah, exactly. What other key takeaways did you put in your session here today?
Well, the two most important things for me were just to say that, first of all, the planning is extremely important trait that we shouldn't skip or give away when we are using this tool. Second would be that you need to be experienced to use these tools because it requires more attention to try to distinguish when you have a problem. And I think that the most important thing to remember is that throughout the whole process, we need to think about calibration. Still, we shift from the patient to the screen of the computer and then back again for surgery. And these transitions between the two worlds needs a lot of calibration in order to make sure that we are actually drilling where we think we are. So,
do you see a difference between the scientific literature where a lot of progression on accuracy is being reported versus the clinical reality?
I think if you look closer at the literature, you will see that as well. Because sometimes you look at the studies and you see the mean number, which is quite good. You see standard deviation, which is strange, because sometimes you use guided systems and then you have a deviation of 4.5 millimeters or 3 millimeters. Deviation of 3 millimeters is like
huge.
Yeah, it's enormous.
Yeah.
So how come we were using guides and we have such a deviation? And this is exactly a problem of calibration, that maybe it was someone that is not experienced doing this case, or maybe there was a problem of calibration of the data in the data acquisition stage. These process errors, we still don't know which part will play a greater role, but I think all parts needs our attention equally.
Exactly. I hear you say that again and again, and it's all about properly planning, being involved in the treatment planning. What is in daily practice perhaps preventing professionals from actually taking the time and diving into that entire workflow and process?
I think that the lack of accessibility to software.
Okay.
But also today, if someone wants, there are a lot of free software that will enable us to virtually plan on the CT image and even make some virtual wax up. It will not be possible to take this planning and to create a guide out of it, but at least it will give you a feeling what are the problems of your case and the challenges of your case, and then to decide whether you want to take it a step further and use a guide in this case. And I think it's important to emphasize that, like in everything that we do, a learning curve is needed.
Yeah.
Especially when you are acquiring a tool that can be very colorful and advanced and convincing, but you need this supervision. And it's very easy to think about, ChatGPT. When you ask the ChatGPT to write your CV, you will get a result that is very polished and very well structured and very comprehensive.
You also get a few interesting new jobs, probably.
Exactly. So some facts might be made up.
Yeah.
So this is exactly the situation. You need to make sure that you verify whatever you get and don't trust it blindly, although despite the fact that it's an advanced and new technology.
Now, Tali, the learning curve is very important, but say you're already 20, 25, 30 years into your career. These new developments come on the market. It doesn't feel very comfortable to go back into a new learning curve, in this case, into the digital planning or working with these different guides. What would be your argument to actually help people jump that divide? How do I, me who has everything established, I'm working my workflows as I've been doing for the last 15 years. It's uncomfortable, right, to try new stuff?
Absolutely. You are very used to the way you work, and when you work guided, you have to trust the system to a certain point. And first of all, the literature shows without any doubt that also experienced clinicians that are performing 1,000 implants per year and even more, they will be twice more accurate if using a guide than doing freehand.
Okay, so first argument backed up by science. Science tells you I get better if I go over the fence.
Yes, but I think that it depends also on your personality, whether you are an adopter of new technologies or you are very, very conservative and reluctant about trying new things. But I would suggest that just to try and examine yourself and try to take a simple case, just as a test case. Take a simple case that you would do easily. And even if you're not implementing the guidance, just on the screen of the computer, try to simulate the case, and then you can recheck yourself and see that maybe if you light up the wax up, then the position of your implants would not be the same one as you would have done freehand. So there are a lot of exercises that you can show yourself that you can actually have a benefit of it. And I think in dentistry, or medicine in general, we get to a certain point of experience that we don't have coaches anymore.
Right? Because you're the best in the room.
Yeah,
you're the senior.
But also when you look at the Olympic athletes, they have coaches, and they are also gold.
The best in the room.
Yeah, the best in the room. So how come we don't get any more, to a certain level, we don't get more coaches? I think this is an opportunity to teach yourself, to get an artificial coach and push yourself to a better level. We all should be a little bit more modest and understand that we can always get better.
Nice. That's a very nice message to take out of this session. Be a little modest, and even the best Olympians in the world still have coaches, and perhaps using either dynamic or static guides and a digital planning could help you to even get better, even if you're already top level notch, right?
Exactly.
Beautiful. Thank you very much, Tali, for sharing your insights.
Thank you.
And thank you for watching this episode of Tell Me More About. If you want to learn more, make sure you check out all the other available Tell Me More episodes and all the other educational, scientific content on Monaco Online.